Hello, everyone. This is Sherry with the CGH Health Foundation, and today is one of our Growing Healthier programs for Facebook Live. All of our Growing Healthier programs are done here on Facebook Live at 12 noon, usually on Thursdays. And if you miss one, don't worry about it. You can just go to the CGH website, click on menu, and look for the YouTube and radio interviews under our Health Resources column. So Tuesday, August 1st was World Lung Cancer Day. And for this month, we decided that we would invite our new pulmonology provider, Dr. Altaya, to speak with Dr. Bird about lung cancer. And I will give you a hint, it's not just of a concern for smokers. And so I think you'll learn a lot about that today. Looking forward to next month. September is Polycystic Ovarian Syndrome Month, which is one of the more common disorders for women, ovulatory disorders for women. And our provider, Dr. Anna Biedudin, is going to come and talk to Dr. Bird about PCOS, or Polycystic Ovarian Syndrome. Women's health is a very important aspect of the Health Foundation. We focus on that and provide financial assistance for women for their screening and diagnostic mammograms and ultrasounds, and for their annual gynecological exams as well. And so I just want to remind you that the Health Foundation's annual campaign is ongoing. We're still accepting donations. And to get more information about donating, you can again go to the hospital website and look for the Health Foundation page. With that, I will go ahead and turn it over to Dr. Bird and his conversation with Dr. Altaya.
Thank you, Sherry. I appreciate it. So, let's get Dr. Altaya on here. Hi, Dr. Altaya. Welcome.
Good afternoon, Dr. Bird.
Glad to have you on here today. So, a little bit paradoxical that we're talking about growing healthier and lung cancer in the same sentence, but it's part of life is that some of these things occur. So glad to have you here talking about it. So
thank you.
Yeah. Dr. Altaya has been here at CGH now. Gosh, help me out. When did you start?
April 1st.
April 1st. Yeah. So he's been a sensation here at the hospital. He's been doing a great job. Great to have around. I know one of the things that we're really excited about is that you, in addition to seeing patients in the hospital, you have your clinic practice, and between you and your nurse practitioner, Angie, I know you've been able to add some continuity to patients and seeing them in the office, and that's been really good.
My pleasure.
Yeah. So let's get into some questions about lung cancer, though. So first thing I just wanted to ask you about is how common is lung cancer?
So lung cancer is it is a common disease, and it is a very serious disease. I would say about 10% of cigarette smokers will develop lung cancer. This year, in 2023, there will be over 240,000 newly diagnosed cases of lung cancer.
Okay.
And when we look at this worldwide, over 2 million diagnoses of lung cancer, with over 1.8 million deaths from it. So it is a very serious disease. For example, when you look at the most common cancers that you can have as a man or a woman, it's the leading cancer diagnosis in men. After that, you get prostate cancer. In women, it's the second most common cancer. First is breast cancer, and then lung cancer.
Yeah, that's pretty sobering stuff. So, hey, before I forget it, I forgot to mention at the outset here, Dr. Altaya is a pulmonary critical care physician, just for those who are watching, in terms of his expertise, where that comes from. So
I actually also enjoy neurocritical care.
That's right. You're certified in that as well, aren't you?
Yes.
Yeah. Okay. So neurocritical care is people have brain type of things going on. Is that right?
Strokes, intracranial hemorrhage, aneurysms, and whatnot.
Yeah. Okay. So let's just talk about, the patients that you see. What are some typical and maybe even some not so typical symptoms that you see in patients who eventually get diagnosed as having lung cancer?
So from a symptom perspective, uh, what are the most common manifestations? So you can have manifestations that will happen in the chest. So we call them interthoracic manifestations. And then you can have extrathoracic manifestation, things that are outside of the chest. And it depends on the stage of the disease, what symptoms that you can develop. So most commonly, if it's within the chest, a cough. It can start off suddenly by a cough. About 50% of patients will have a cough. They can cough up blood, hemoptysis. Patients may develop shortness of breath with exertion, and that could be a little bit difficult most of the time. These are smokers, so they already have some shortness of breath because of smoking, but worsening shortness of breath may be a sign of something is going on in the chest cavity. So, and as well as depending on the stage, if the cancer begins to grow within the chest, you can develop chest pain. If it begins to rub against the lining of the lung, it can cause pleuritic pain or even going into the rib. So you have interthoracic when it's only localized to the chest, and then you can have what we call extrathoracic manifestations. And that will depend on the type of cancer that you have. You can break down lung cancer into two major categories: small cell lung cancer versus non-small cell lung cancer. Small cell is the most aggressive type, and this type of cancer likes to go to the brain. So if it leaves the chest and it develops lesions to the brain, patients may develop headaches, change of vision, imbalance, so that you can have these what we call extrathoracic manifestations. If it goes to the bones, if it metastasizes to the bone, God forbid, you'll develop bone pain. And it is a very strange disease. We can also develop what we call paraneoplastic syndromes, where you have it begins to release certain chemicals in the body where it affects different hormones. For example, subtle blood tests will be elevated. For example, your calcium may go up with certain types of lung cancer. You may become more thirsty, wanting to drink more, SIDH. It can also cause strange muscular weaknesses, something similar to what we call myasthenia gravis. The other name for it is called Lambert-Eaton syndrome, where it causes release of certain antibodies which weaken our muscles, and patients will have difficulty walking around. So it depends on, the symptoms will depend on the stage of the tumor, the size of the tumor, if it's only localized to the chest, if it's gone outside of the chest and metastasized. So all these will give you different types of symptoms.
Will lung cancer be one of those cancers that causes you to lose weight and or have, like night sweats and those type of things?
So definitely these are like the regular signs and symptoms of malignancy, where patient can have fatigue, tiredness, loss of weight, loss of appetite, night sweats, like you said, Dr. Berg. Yes,
okay. So you've already alluded to like 10% of smokers go on to develop lung cancer. Are there any other substances or occupations that cause someone to be at a higher risk of acquiring lung cancer at some point in time in their life, Dr. Altaya?
So like you said, smoking is our known culprit, number one. And the way I've seen this and I've read about it is things that can progressively cause damage, wear and tear on the lung can do that. For example, patients that smoke marijuana, cocaine, this can also increase the risk of developing lung cancer. Cigar smokers, pipe smokers as well, not only just cigarette smoking, but both that. And it can also cause head and neck cancers in the back of your throat, in the vocal cords. So not only the lung, but can be upper respiratory tract. Something to watch out for, and I've checked in my home, is radon. This is very important, especially in Illinois. Radon is a gas that's emitted from uranium. and you can get radon testers, especially in your basement, to make sure that those levels are within a normal limit. Radon is a small chance of developing lung cancer. Patients that have worked with asbestos, pipe fitters, electricians, all that throughout the years, it not only causes asbestos-like injuries such as mesothelioma, but it also increases the chance of developing lung cancer. Patients that are all the time around diesel fuels, diesel exhausts, is also increasing the risk of lung cancer. You can even have certain viruses, oncogenic viruses, like human papillomavirus, can develop something called squamous cell lung cancer, one of the non-small cell lung cancers. And sometimes patients that have recurrent injury to their chest from radiation can also rarely develop lung cancer.
How about folks that are exposed to, like, I think of folks that get exposed to like things that smell bad, or like, let me just give you an example. Like if you work, if you're a painter, or you work in a body shop, or you know, those kind of things. What would you say about those?
So I have not seen that there's any direct link to it. It may be certain confounding factors within there, but one specific chemical, I have not read about that, to be honest with you.
Okay, good. So obviously the goal is to try to prevent lung cancer and not have it in the first place. So I wanted to make sure we talked about what you could do to prevent it. But there are you have mentioned now several times about what stage the cancer is in terms of symptoms that patients have, and also their life expectancy, how they're going to do, depends upon how soon this caught. So I want to talk a little about lung cancer early detection and how that can be life-saving. So one of the things that, you know, we have at our hospital, and I think a lot of hospitals have these days, is called a lung CT scan, kind of a test to check for if you have any early concerning nodules that could be actually early lung cancer. What are your thoughts on that? And also, what are the recommendations for who would be a good candidate to consider having that test done?
Thanks for pointing that, Dr. Bird. I just want to also point out one important factor here. I forgot to mention it, is that lung cancer is the leading cancer death worldwide. I want to make sure that our audience understands that this is a very serious disease. If you combine the amount of deaths from colon, breast, and prostate in 1 year, they will not equal the amount of deaths from lung cancer.
Wow.
So it is a killer. And it is not a simple disease to diagnose. We do have tools, like you mentioned, lung cancer screening has been adopted over the past 5 to 7 years, where we use a low dose CT scan of the chest, so low radiation from that. And patients that are between the age of 50 and 80 years of age that have smoked for 30 years or more would qualify for a low dose CT scan of the chest. This tool allows us to look at the lung tissue to see if there's any lung nodules. That being said, it's not simple just to go in and biopsy a nodule because they come in different sizes. When a nodule is more than 8 millimeters or more, we can utilize another test called a PET scan, because that's when its sensitivity becomes effective. Depending on the PET scan findings, then we start considering doing a needle biopsy or something called a bronchoscopy. So bronchoscopy is something that I do, where I take a long tube with a camera at the end of it, like an endoscopy that you've done, anybody that's done a colonoscopy or an EGD, We take a long tube with a camera at the end of it, go through the mouth, into the trachea, go down into the windpipe, into the bronchial tubes, and attempt to take a biopsy. This will allow us to take biopsies of the lymph nodes as well as the lung nodules, if need be. Another way to biopsy these, depending on the size, is a CT-guided needle biopsy. So they would do a CAT scan of the patient, and while they're doing the CAT scan, aim the needle to enter through the skin into the lung tissue to get a biopsy of what those nodules are. And depending on what that shows, it will help dictate your treatment. You decide the stage of the cancer and how to treat it.
Yeah. So, and all those things, just for folks to know, all those things that you're talking about, Dr. Altaya, we do those here.
Oh yeah.
Yeah.
We have a great team here.
Yeah. How about the e-bus that we've, I know you do those. How does that fit in, or does it fit in with lung cancer?
Absolutely. So that's part of the staging process for lung cancers. Anybody that has been diagnosed with lung cancer, you would need to evaluate the lymph nodes, which are in the middle part of the chest, in order to understand what stage. If the cancer is only in the lung tissue, then that you talked about that as stage 1. If it's gone to the lymph node, then it would become stage 2 or 3, or depending on where the lymph nodes are. So the e-bus is a bronchoscopic procedure where you take a long tube with a camera. The end of the scope has an ultrasound at the end of it, allowing us to look at those lymph nodes. And we take a very small needle through the bronchial tree or the trachea and place it into the lymph nodes to agitate the cells there and absorb them to see what kind of cells there are. And it will allow us to know if there's any invasion of the cancer within those lymph nodes. It's an outpatient procedure. Usually this is done with anesthesia. It takes me about 30 minutes to do this. I can biopsy essentially all the lymph nodes within the chest. Minimally invasive procedure. Again, it takes about 30 minutes. We watch you about 30 minutes afterwards, and you go home. It helps guide the oncologist on how to treat these tumors, and as well whether or not we need surgical intervention, because we have medical intervention as well as surgical intervention for these tumors.
One other thing that you mentioned, just for the folks that are watching, PET scans. And first of all, I thought it's interesting that you would say to do a PET scan if you have something that's concerning before you even consider doing a biopsy. But can you talk a little bit about what a PET scan does and how it gets its information for you to know about?
Yeah, thank you. So I just want to also take this a step backwards. So if you did a CAT scan on my chest, you'll probably find some lung nodules. I've never smoked. Most of lung nodules, I would say this, are benign. Biopsying the lung is not a simple ordeal. There are complications associated with that. You can collapse the lung, you can bleed in the lung, and these can have bad repercussions. So the PET scan is a tool that allows us to identify areas with high intensity of inflammation within the lung or even through the body. So it's a scan that will scan us from our skull all the way down to our thighs. Specifically in the lungs are they're full of air. And if they have inflammation in the lung, that should not be there. And depending on your clinical history, smoking history, exposures, we help utilize the PET scan to whether or not you would require a biopsy. Some patients will just have serial CAT scans and monitor these nodules. If they begin to change in size, then we try to intervene and get a biopsy sooner than later. So that's how the PET scan is another tool that here we have at CGH to help us from CAT scans, PET scans, bronchoscopy, CT needle biopsies as well, all here to help diagnose this disease.
It almost sounds like the PET scan helps you it's another piece to help you think about, is it worth the risk?
Exactly.
Is it worth the risk to go forward with a biopsy, or can we wait?
Absolutely.
So, yeah. You mentioned medical treatment for lung cancer, and I know you're not an oncologist, but I'm going to give you the platform here just to kind of talk a little bit, first of all, about some treatments or how the treatment of lung cancer has changed, let's say, in your career, particularly in the last maybe 5 to 10 years, and also give you an opportunity to kind of speak to the work the collaboration that you have with our oncology team here at the hospital, and how you coordinate with them regarding patients who do have lung cancer.
Great questions, Dr. Bird. So just briefly, again, like you mentioned, I am not an oncologist, so I truly depend on our oncology team here, Dr. Ali Khan and Dr. Syed, it's a pleasure to work with, both brilliant physicians, very well respected, very caring individuals. So the treatment will depend again on the stage of the cancer. It ranges from stage 1, which is limited to the lung, to where stage 4 has already spread out of the lung into different body parts and whatnot. So that's what we call metastatic lung cancer. Stage 1 lung cancer means that it's not past the lung tissue, has not gone into the lymph nodes, and the best treatment for that is to cut it out of the body if your lung capacity allows. So the lung is a very important piece of real estate. If you have no lung capacity to breathe because of smoking for 50,000 years, cutting out your lung will not benefit you. You won't be able to breathe afterward. So you have to choose the patients properly. Now came along the new advent of what we also do here at CGH is single beam radiation therapy. I've had quite a few patients where their lung capacity will not allow them to even biopsy the cancer, to tell you the type of cancer that they have. And they will definitely not have enough lung capacity to remove that cancer. So for stage 1, very effective is single beam radiation therapy that we do here at CGH in order to help eliminate that cancer. Now, if it's gone beyond the lung, we would need to use chemotherapy, radiation therapy, and now the latest and greatest is what we have is called immunotherapy, where we're attempting to use your own immune system to fight off these malignancies. It has really changed the scope of practice, I think, in oncology. It has become essential. It has definitely given our patients much more hope in the fight and battle against this terrible disease. So it's important that the patient realizes that lung cancer is a deadly disease. You need to take an initiative as a patient to cut back on smoking if you are a smoker. And there's always hope. Patients that have reduced even their cigarette smoking to less than 15 cigarettes, less than 10 cigarettes, will reduce the chance of getting these cancers. If you've eliminated smoking, that will also help reduce the chance of getting lung cancer. So there is definitely hope here. But the patient has to cooperate and get away from this bad habit. Just a positive perspective here. Over the next 50 years, since patients are quitting smoking compared to where we were 50 years ago, there will be a considerable reduction in amount of lung cancers that we will be developing in the United States and worldwide. Over 25 to 50% reduction over the next 50 years by reducing smoking.
Yeah, that's really good to hear.
So that our patients, we can help, but the patient needs to take the initiative to stop smoking and get these low dose CT scans of the chest. If you smoke for 30 years or more, are between the age of 50 and 80, tell your primary care physician to order you a low dose CT scan of the chest.
Very good. At one point of clarification on the radiation treatment. So just so folks understand that that's actually done at Northern Illinois Cancer Treatment Center, which is between Sterling and Dixon. And it's kind of like it's jointly owned by CGH and KSB. So,
okay. I didn't know that. Okay.
Yeah. Hey, you're new. So it's kind of its own entity, even though I know you work closely with Dr. Hatum and
yes,
and everything there at that center. So, well, hey, Dr. Altaya, thank you so much for taking a little bit of time to talk about lung cancer. And for those who are watching this and are going to watch this later, I 100% back this, that Dr. Altaya is just an outstanding pulmonary doctor. So if you, I hope you don't, but if you do have issues and have concerns about maybe I have lung cancer or I have other pulmonary conditions, Dr. Altaya is absolutely your guy.
My pleasure. Thank you.
Yeah. Thanks, Dr. Altaya.
Have a great day. Thank you.
Okay. So that's our talking about lung cancer episode. I want to give a few shout outs and talk a little bit about what's coming up next month. So Rebecca's going to team me up. Thanks, Rebecca. So first I want to talk about ReadyCare. It's new and improved. So the hours are expanded. You can see down below there that from Monday through Friday, it's 8 a.m. to 8 p.m. and on the weekends, it's 8 a.m. to 1:30 p.m. We've also added X-ray, and you can read the rest of that. But we're doing more treatments down there: stitches, sprains, strains, fractures. So if you have something that you don't think that warrants being in the emergency department, ReadyCare is there for you, and they're there for you more than they were in the past, just in terms of the hours as well as the work that they're able to do to help you out and your family. Okay. Hey, employee of the month, Lori Wilkinson. Hi, Lori. Lori does a great job. She's been with CGH for quite a while. She works at our main clinic at the moment, and I want to congratulate her. Back in the day, she worked down in Walnut at that clinic. So congratulations to Lori. And then want to congratulate Mary Jean Darrenberry on her retirement. She retired after 50 years here at CGH. So congratulations to Mary Jean, and wish her the best in the best wishes in her retirement. And yes, next month, Dr. Anna Beta Duden, one of our new OB-GYN physicians, will be here and talking about polycystic ovarian syndrome, because it's PCOS month. I'm not going to try to say it again. Anyhow, looking forward to having her. You'll enjoy her. She's very entertaining, and I think she'll have a lot of I know she'll have good information for you about PCOS. All right. Well, hey, thank you for those of you who've taken the time to watch this broadcast. Please feel free to share it with those around you who you think might be interested. And as always, hope you have a good month. Enjoy the rest of your summer, and I will see you back in August.